That was a very short lunch. It felt like there's so much conversation going on. But I would like to move on now to our next speaker, who is Dr. Imran Bashir, a colleague of mine in South Yorkshire. Imran works at Rotherham Hospital and is going to talk about using the data, using the strategy into practice.
Good afternoon, everyone, and welcome to my presentation. I hope you're all having a wonderful day today. So my name is Imran. I am one of the consultants at Rotherham Hospital, and I'm here to present our QI project. So my presentation will be focused on highlighting how a skill mix in diabetes team can not only make a difference to quality of care, but quality of care as well, because that's what it is important. So let me start by saying a few words about background to our QI project. Our NPDA data of 2022-23 showed that we have 64.5% of children in two most deprived quintiles, and about 10% of our patients were from ethnic minority. Moreover, our figures showed that the uptake of new technology in our cohort was very low. As you can see, we were 33.3% as compared to 48 nationally and 56 regionally. That was for continuous glucose monitoring. And then moreover, same was reflected in hybrid closed loop, very low number, 4.1% as compared to 14 and 21 nationally and regionally. It was reflected in our HbA1c. So although our mean HbA1c, we were positive outlier, which was very good, but you can note that our HbA1c less than 48 and less than 53, which is supposed to be a good control, was less as compared to the numbers nationally and regionally. So it meant that simple 3 lines that we had lower number of patients on new technologies, our HbA1c was good, but the target one, which is 48 and 53, was much lower, and we had some work to do. Now, that leads to the project. So we all know that there is a national drive of dealing with inequalities of care and poverty, and at that time it was really highlighted nationally and local ICBs. We were very fortunate that our local ICB was very much, in looking into figures, and NHS England, they realized that we do need some help, and they gave us an opportunity of giving us a project. And the project was that we were given £50,000, and that £50,000 was 1 year fixed term, and they said to us, use it the way you want to use, but show us that you can make a difference, which we obviously wanted to make a difference. So how we used the money, we employed a whole-time family support worker, and we also gave 1 extra day of specialist dietitian colleague. I will come to the roles in a minute. And that was a fixed term appointment from April 2023 to March 2024. And the focus of our project is very obvious. We wanted to have uptake of this technology to all the most deprived quintiles. And we also wanted to make a difference. We wanted to show that if we do use this project to reflect how the quality of care and equality can be made better. So I will just summarize, the family support worker. She did an amazing job. So before obviously go to her role, our team made a comprehensive plan, because as you all know that when you appoint a new person, you want to train them comprehensively, because you want to make sure that they know their role and what they are doing. So our team had few meetings. We had a comprehensive plan that how the family support worker will be extensively supported in the first few days and weeks, and then how we will keep on monitoring how she's getting on with her role. Her role was very important. So she has to, she signposted, demonstrated technology to patients. So she picked a patient from the cohort, and then after picking the cohort, she started the technology pathway, and then she gave a more extensive support to individualized family, which was not only in outpatient clinics, inpatient, and including home. So, for example, how to connect the technology, how to use the technology, how to look at the data, how to download the data, how to look at My Life app. So all the minute small things to the complex things, which were very difficult for us to do on our own. Family support worker took this role amazingly good. And moreover, I think one of the role of family support worker was that when she reviewed the data very regularly. So she will review the time and range, the data, and she will point it out to our diabetes team, diabetes nurses, consultant, whoever is available, and then we will give a task that let's do this, this, this. And she will go and implement that data working with the family. So focus was that we get new technology but also maintain the support. Next comes to our dietitian role. So she has done an amazing job. So I'm really proud how she has dealt with whole. So she steered the whole project along with the data monitoring and also reporting the data. She had a full review of patients starting to technologies, dietetic review, giving them leaflets, then targeted support to the families, and then looking at their time in range. Along with it, as you know, the dietitian has got a unique role to play in any diabetes team. She was giving extra appointments to patients, how to manage the activity, hypo treatment, timing of insulin. So all these roles did paid off in the end, which we will come in next few slides. The other thing my family support worker team member and dietitian did was signposting to these families to number of support groups which were available, the resources like exercise group or some local group, local patients group. So they also kept on signposting to various areas, which was very good. So family support worker, we already said that she will review the data. So yes, and then signposting to some of the groups. This is some of our diabetes team cohort patients. Right, so this is a good example. So the family support worker picks up that this patient, as you can see, the time in range is not very good. The BMs are gone to 9.7. And when she signposted to us, we had a look and explored what is happening. And it looked like this patient was missing a morning snack insulin. So we obviously, target the approach, and you can see how it did improved. Just one example. Now, obviously, it needed a full team support, and we had monthly meetings, and we dedicated time, which meant, that the family support worker will bring the cases to us. We will discuss as a team. We will make a comprehensive plan, and then we will task the family support worker to do certain jobs, and then review them back in the next clinic that how things are working. So the whole team was, absolutely involved in this project. And then we needed to submit data every 2 months to NHS England. And again, huge thanks to Janet, our dietitian colleague, who was actively looking at the data and submitting it every 2 months. It sounded a lot of work, and it was a lot of work, but we were very keen to get most out of it. Now it brings to the outcomes and improvement, how it made a difference. So you can see these are the data from April 2023 when we started the project until December. 2023, you can see that we have 64% of the patient from two most deprived. Sorry, this white, this should be gray. Somehow it has come as white. So you can see lots of patients being recruited from deprived area. The next slide is our current caseload. And again, we have gone from very beginning 33%, now we have got 80% of type 1 caseload and 114 on CGMS. So huge improvement in recruiting patients. Now the next question will be obviously from many of us that, okay, you have recruited, but have you been able to maintain it, and has it been reflected in your results as well? It did. So this slide you already know, but you can see our median HbA1c in 2023 was 59.6, and the mean has dropped to 54, and median has dropped to 53, which was a huge improvement in our cohort of patients. Moreover, you may recall in the first few slides, I did show that our less than 48% and less than 53 were far behind to the national and regional level. I do apologize, I could have uploaded that slide, but once I sent the slide, I realized I have not uploaded, so I do apologize. That slide shows that we are equal and comparable to national and regional figures from the most recent NPDA download dashboard. So that gap has all been covered as well. Now, summary is that we did close the gap related to deprivation. As you can see, 66% of current caseload is from two most deprived quantiles, and 63% of hybrid closed loop are from two most deprived quantiles. And interestingly, this one, 12 out of 13 from minority group. So we only had one patient from minority group. Not because we did not want it, it was so challenging from some of the deprived areas that no matter how much you convince, it was the support required for them was not easy. And without the family support worker, individualized support, it was not possible. Moreover, how it helped us that the family support worker, when she was targeting or giving a targeted approach to these patients, our diabetes nurses and rest of the team were more free to do a number of other jobs. So it did free their time to do a number of things which they were doing without this family support worker. I have included some examples. I think they are good examples. And so let's say first one. This is a 16-year-old child. The names, obviously, we have just anonymized them. This child, through being diagnosed with diabetes nearly 6-7 years ago, the control has always been poor. The HbA1c has always above 80, most of the time above 90. So we tried to convince this family to take new technologies, but they declined. They did not want to put this work up. It's a 16-year-old. The priority is not to learn some new gadgets, so he's not keen. So we said, okay, let's do weekly visits, let's support. And it did improve. You can see the time in range improved, the blood glucose improved, the HbA1c improved from 69. But as it happens, it came to holidays or time off, and he slipped off again. So reluctant to, and then it dropped to 16%. We thought, oops, we should do something more. We kept on trying. And he had 2 episodes of high ketones, nearly DK, got admitted a couple of times. And we finally somehow convinced, we said, let's try. And if it doesn't work, we will go back where you are, so why not give it a try? And again, a good job by the whole team. So we tried the new technologies, and you can, and time in range is 71%, which is amazing. And the family says it has changed our life, they regret why did we not adopted these new technologies before. This was a very, very good example for us. This was a new patient, and typical example how the inequalities can make a difference. So this is a 2-year-old child from the most deprived quantiles. It's a family from ethnic minority. The family doesn't speak any English. And moreover, they have got 2-week-old baby at home, and this is a 2-year-old child. So the priorities, you can understand how difficult it will be. And amazing job by all the team. So we arranged, obviously, interpreter, family support worker, had lots of sessions with them, and you can see the results. All changed so much, yeah, and still maintaining, which is very good. One more example, a 10-year-old, and this family, there is a sibling already with diabetes, and the family, mom's understanding was reasonable, but she was unable to write, and she said, look, I want to have gadgets, but I can't deal with it. And historically, the sibling had a very poor control as well. So here, lots and lots of input from family support worker, dietitian, and the diabetes specialist nurse involved. We gave very frequent appointment in clinic every 4 to 6 weeks. Lots and lots of input, and amazingly, this patient HbA1c improved to 56 from 71, and that was over a short period of time. So from one to another, 3 months time. So the family now realizes, and they wish the sibling who is now 20, they could have gone for the same new technologies approach. So feedback overall, some comments we just took as a survey, and they all say it's life-changing. It has made a difference. They feel like a new normal. They feel like they are not diabetic. It looks like they've got their life back. So lots and lots of good feedback approach. If we can play this video by any chance, please. Thank you.
So what do you like most about your friends?
That I get to do swimming and gymnastics.
What does one thing look? It's been a game changer, hasn't it? So we can sleep through the night, and I have that reassurance that the pod is going to do its thing and just kick in if she goes high, or stop if she goes low. Activity mode. So when you do swimming, put activity mode on, so it does help with those hypos, doesn't it? So what do you like most about having your pump?
That we don't have to do finger pricks.
Like when she was first diagnosed, she went just really lethargic and just laid on the floor, and I had to do a finger prick to check to see what she was, and she was really, really low. But having the Dexcom and the pod has just helped, because you see that happening, so you can stop it. When she's been poorly, we've been able to manage that. It's just rather than having to come in to the hospital.
When you eat, what did you have to do when you
Can you remember?
Food?
Yep, that would be injecting the leg with insulin.
Now we've got your pump.
Yep.
What do we do?
We get the phone and we put your carbs in, and that's it. And it does it for him. He doesn't like having diabetes, that's the problem. Would you go back? No, you wouldn't, because you say that every time. We do it once every 3 days instead of 3 or 4 times a day. Yeah. And we don't have to prick your finger very often, do we now? It'd make my life so much easier. But unfortunately you've got it, so we've got to deal with it. So yeah. So we just have to deal with it best we can, don't we? Yeah.
Amelia, do you know when you're eating, how do you know your numbers?
I have pods, then I just check me when I eat, when I do medicine, and I eat food for my dinner or breakfast.
Excellent.
Or tea.
Wonderful job.
It's just so much easier than having to inject her, and just she's got a bit more freedom. It's not having to do the needles all the time.
And how about the impact on day-to-day release?
At first it was hard, but we get used to it now, and I just think it's just part of us now. What activities do you do?
Swimming.
Swimming. On a Tuesday we go to, where are you going later?
Squirrels.
Squirrels. And on a Sunday we go to
Gymnastics.
So you can do all the things that other boys and girls do, don't you? Yeah.
Including spinning on chairs.
Spinning on chairs.
That's the favorite part. So for overview, it doesn't end there. Obviously, you have to maintain the control, and you have to focus on keep on engaging the patients and supporting the families. Our family support worker has been actively involved in the seamless transition program, and obviously we're thinking about supporting patients with type 2. So summary is that this project results obviously demonstrate that with a skill mix and right investment, right targeted, individualized training and education support, you can make a difference. You can definitely make a difference. And some of the parents, the way they really felt with this technology and support was amazing, and it was amazing feedback. Having said that, there are challenges, and I thought I will just say this because the biggest challenge is not your commitment. I'm sure you all are very committed, and we are, for our patients. The biggest challenge is to getting the financing. So this one was 1-year project. It was extended by, believe me, we had about, at 7 different forums I raised with my team, number of meetings, data backup, and the data speaks for itself. We got it extended for 10 months. And then the further extension, now we are given 6 weeks extension, so it ends on March yet. It's very difficult, it's not easy. I had a meeting with executives, ICBs, and the amount of grilling you face, it's very hard to prove. But I will say, don't give up, and I am not giving up. I'm not giving up until we make sure that we get this funding approved ongoing. Lots of good signposting by Dee herself, Fiona Campbell, how to try to get the funding, and I have used them all, and they were very useful, and otherwise we would not have got this extended for so long. But I am hoping that we can keep this funding ongoing. So a huge thanks to all our patients. Without them, we could not have done it. They have done an amazing job. And a huge thanks to my whole diabetes team. I'm proud of them. They are amazing team. They really put their passion behind this project. And yes, we did achieve it, but it was not without the help of my good team and lots of other good people. Thank you.
Ben, thank you very much. We have time for a couple of questions. And Armani?
Thank you. We just have a couple of questions from people attending online. Well, it's 2 of the same question, actually, which was, what was the background of the family support worker and what training were they provided?
Interesting. So she was working as an outpatient receptionist. So she did not have any diabetes experience, but good thing was she had a passion, and we saw that passion when we interviewed her, and that paid off. So that's why it needed a good comprehensive plan. So for first 4 to 6 weeks, it was all her observing and going to all our training, teaching sessions, clinics, what to look for, how to connect. So yes, we did need to train her, but she's an amazing, passionate person.
Fulia?
Thank you. That's a really wonderful presentation. Thank you so much for that. I was just curious, so a couple of things. With your family support worker, was she doing anything clinical at all, or was it more, you mentioned about apps and technology support, and, I'm sure she did a huge amount to enable families to sort of access the care, but I was just interested whether she did anything clinical. Yeah. And then secondly, I'm not sure how diverse your patient population is, but was there anything around trying to ensure that your workforce is representative of the patients that you look after, and was that a consideration at all with the family support worker role?
Yeah. So family support worker flourished with the time. In the beginning, obviously, she had less clinical knowledge, and more was to show her how to connect technologies, how different technologies work, and then more of sitting in clinic, seeing what the time in range means, when she should pick up. much of it was involved in going to these family houses and show them connecting, downloading, how to look for, and what you look for. But with time, yes, she has started recognizing the clinical role, and she does. But certainly it is not without a supervision. It is always a diabetes specialist nurse, dietitian colleague, or so she can always, she does sometime email us that I have noticed that this thing has changed in this family, what do you recommend? And then the call, if it is two clinical questions which we feel that it is more of a depth of a specialist person like diabetes specialist nurse, then we address that accordingly. So it has now she is enrolled for 18 months, and you can see that she has got a good knowledge that which patient is slipping off, which patient is going in the right direction. So yes, it has changed with time. A second question, diversity-wise, our population is quite diverse, as you can see, but more was that one of the, if I have got the question wrong, and so please accept my apology, many of our patients were from very deprived area, and the challenge was to make them understand what the technology meant. And they all felt in the beginning that it is more of a new gadget and it will be a daily job to look at. There will be lots of alarms. So we tried to address by having more support. Was that the right question answer, or was it a different? Do you mind saying it again?
Well, it probably depends a little bit on the population that you serve, but I was just wondering whether, when you were thinking of the family support worker role, you know, if you're thinking about the families that you look after where you think actually our traditional healthcare professionals for some reason are not quite able to do everything that we need, and is there a missing link, and is it something around representation, or is it, you know, so sometimes with the family support worker, I know in some of the projects what teams have looked to is somebody who perhaps has links with a certain community or can bridge that gap. So I just wondered whether that was something that you needed to consider or not when you were making the appointment.
Yeah, we did consider that because our own diabetes team is quite diverse in representing, and we did keep this in mind, keeping in mind the culture and the background they're coming from. Yeah.
Thank you, Imran. One thing that you haven't you've touched upon, but you really fought hard, didn't you, for that extension of funding, and that sounds like it's under threat again. So bring that up in the GIRFT review. Try and demonstrate the impact not just to the families and the outcomes, but also the additional hours that your core team have got now to focus their expertise on.
Absolutely. I think the challenge teams will find, and I'm telling you from my experience, is that the finance people will come from various, so for example, do I have a couple of minutes here? So for example, when you ask ICB to give money, they will say, we are paying you this much of amount, and first prove that you are spending that money correctly. And when you go to your own financial team, trust financial team, they will say, oh, we are spending, we will give you breakdown, but when it never happens. So they will never be able to give you a full breakdown of we ask so many times. And when it goes to trust to give the money, the last meeting I had was with the trust executive, and it was 15 people sitting. I presented my business case, and actually we gave I presented lots of it, and they said, how is it going to save me money? And I'm trying to tell, you will save the bed, this. They said, no, we get a block payment, so we will get the same payment. So your argument about saving money is not the one which will, so it should be ICB commissioner should be giving the money. Why should we? So it goes backward and forward, and you get surprised at, the way how the finance is looked at. And I actually got a huge experience to see, how, because they will have a reason of everything. They will say, oh, well, we are giving you this money, this is a block payment we are getting, we are not getting now best practice tariff, something like this, Or if they are getting best practice tariff, they will say, well, we are already spending. But it's very hard to get the details, like where the money is exactly spent. Like for us, we really want this project to go family support worker and the dietitian work as well. The last hope we were given that they may extend the family support worker, but not the dietitian work, but that's even not, they said we will wait for the ICB to come back to us. So it's extended up to end of March. So that creates challenges because obviously you have appointed a person who has left their permanent job for this. And now they are just waiting that what will happen, and they want to look for new jobs, and you don't want to lose them. So yes, yeah. But yeah, lots of good signpostings were there though, like Fiona D and Alison Lowe. They all gave me quite useful tips, which I kept on fighting and hopeful for. Thank you.
Thank you very much, Imran. So next I'd like to invite Emma Sparrow, who's from RCPCH&Us. Welcome, Emma.
Cool. So, hello everyone. Thank you very much for having us here. So, I'm Emma, who's the head of Children and Young People's Engagement. We have Anita, who is our Youth Voice Advisor over there, who will wave at us. Thank you very much. And
I'm Krishna, so I'm a Young People's Volunteer for the RCPCH&Us.
So, we're just here to tell you about a really exciting new project that we're doing at the moment with the NPDA. And just to give you a little bit of headline information that's come through some of the sessions we've been doing with children and young people, but also to get your feedback, because as an engagement team, we never miss an opportunity to consult, and you are here for us right now, including those of you online. So if you can scan the screen, obviously if you are online, you will also be able to go to menti.com and then put in the code 83109685. And we've got the first question for you, which is, what does engagement mean to me? So we will just see if you can get in. If it's not working for you, please tell me, because I've got it open on here so I can try and fix it quickly. It's always a plan B. Oh, lovely, it's working. I can see you already responding. So I can see the results, which is useful for me. But I'm going to speak to the results because they're on a different laptop, and what we're going to do is we'll embed them into our slides so that when they go out to everybody as part of the conference materials, and you can see. So at the moment, we have got collaboration being the biggest word. That's what engagement means. We have also got involvement, participation, working together, listening. It's going so fast. Participation, contributing, understanding, impact, clear messages, sharing thoughts, collaboration and working together, and participation are still the biggest words. So what we're going to get from this is kind of a sense from you about what engagement means to you, and that will help us with the engagement project. For us, engagement can mean lots and lots and lots of different things, because for anybody that has been involved in patient and public involvement or children and young people's engagement in the NHS, there's so many words that get bandied around. So we have heard as a team words like voice, patient and public involvement or engagement, patient and public involvement partners, co-production, co-design, participation. And actually for us at our team, what we try and advocate for is don't get too caught up in all the minutiae of all the different parts of the theory that goes behind that. What we're really looking for is an authentic reason to ask, a really genuine way that you're going to listen and then use, and then working really hard together to use whatever you have found out and make a difference with it. So there's lots of engagement specialists out there in trusts or in organisations like ours that can support if you're going into the next steps. But try really hard just to know that actually something's better than nothing. And if you ask two people what they thought about their service and you've never asked before, or two people for ideas about something to do, then that is better than not having gone the extra mile and got caught up in co-production or co-design theory. But for us at the college, it starts with children's rights. And whenever we're talking to clinicians or we're doing training, our children and people from RCPCH&Us have asked us just to go through children's rights super quickly, because it's the framework that embeds why we're doing what we're doing, how we're going to make a difference, and then what we need to do to be successful. So I'm sure if I asked for hands up or for kind of like hands online, for people that have heard of the UNCRC, hands would go up because most people know about children's rights. If we talked about how many of you have got knowledge about the 6 or 7 different articles and how it links to your work and the changes that it makes to business cases, some of the hands come down. And then when we've got left with a few hands up, there are people that might have had a chance to read through the general comments. So from our point of view, it was, as a bit of background, it was written in 1989. There was 5 core countries that took part, and the UK was one of them. And it's there to protect children and young people, to provide the right services and to support their participation. There's only one country across the world that hasn't signed up to it, which is the US. And that is because they have their own constitution and their own Bill of Rights. So it's interesting when you think that we've signed up, that actually out of the developing countries, or the developed countries, we're lowest on the scale almost of how we're doing in protecting children and people's rights. And that's because we're missing the mark on quite a few things. We're actually not involving them in delivery, service design, evaluation and monitoring, which is written into the children's rights kind of like statements. We're also not able to provide, in every case, the best healthcare possible. And we know that because of the waiting times that we've got to get through services, or some of the gaps in service provision that you will have spoken about today, I'm sure, or in other forums around maybe mental health support, or like we've just covered through the day around actually how we make our services really accessible to the whole wider community in the limited budgets that are available. So for our children and young people, they've prioritised Article 12, which is the right to have their voice and views heard in decision making. In the mandate, it says that includes individual and collective, so that it is written in that children and people can be taking part and should be taking part in service improvement and quality improvement programmes. Article 23 is for children and people with disabilities to have, full access to their life and be able to lead a full life. So in health, our children and young people have said, actually that's about making sure there are communication preferences, communication mats, support workers that can help them to understand the information that is being shared with them. Article 24 is why we're always keen to talk with you, because this is why you're amazing and you do what you do. In the guidance around best healthcare and health services, it kind of does go into and leans into actually how can children and people be involved in medical education? How can children and young people be involved in quality improvement? Which is why the audits on the whole tend to be ahead of the game. Article 27 has recently been prioritised by our children and young people around standard of living, and that for us keeps coming up about the burden that children and young people are holding about not wanting to make their parents or carers take them to hospital or GP appointments because they know their parents will have to miss work, or they will have to cover 3 or 4 bus journeys for other family members that need to come. So children and people with conditions are explaining that to us and saying that's why I'm just not letting them know that it's getting worse, or that's why I'm, trying not to mean that they have to take me in for my review appointment. Article 28 is education, and that for our children and people with health needs have said it's really important that they're supported to stay in school, because it can be really hard when you've got a long-term condition. You've got more appointments, actually you might be unwell and not be able to be in school as much. And, something about our service design and how we pull our services together to be 4 till 7 p.m. services might help children and young people to feel like actually all their rights are being met in an equal way. And 31 is about rest, relax and play, which everyone's like, of course children and young people chose that one. But actually they chose it because they've got health needs and they want to be supported to be able to go on the trip. They want their schools to have training so that they don't have to have their mum and dad or their auntie or uncle with them on residentials, or the fact that actually they're always the child that doesn't get invited to parties because there's nobody there to, support either their medication or actually how they can engage safely. So they're kind of looking to us on how we can support some of that. So for us, when we take that into mind, we think about then why this is the right thing to do to have an NPDA engagement project, and it's because it's a children's right. So they have the right to be part of your audit in a way which is different maybe to what happens at a local level, and that's why we're doing something nationally with a number of different charity partners and networks and forums. We've really thought carefully about how it could make a difference, because we don't just want it to be another opportunity where they can fill out another questionnaire and then it gets taken away by some adults to look at the data. Whilst that is a valid tool in some forms of consultation, we want to make sure that there's a way that children and young people can, learn in that journey, and that they can have some skill development, and that it will make a difference to them as part of their, life skills going into adulthood, as well as what difference it could make to the audit landscape. And then what we need to do to be successful, again, we thought really carefully about this and about the fact that actually diabetes is really fortunate in your networks and your charities and the sector support that is there. So just thinking about how we make sure we don't duplicate what's already brilliant, and we work to amplify that and look at what some of the gaps are. If you haven't seen this before, this is like my favourite website link at the moment. Leeds are fantastic. They've shared all of their symbol and PECS materials for anybody to use for free. So it's from Leeds Disability Service, easy on the eye. And we use that when we're doing all of our work to make sure it's accessible. Because, there's really good resources on there about how you do that. So that's also why that picture comes from them, and there's just a link there. So just to talk a little bit about the NPDA project before I hand over to Krishna. So the reason why then we're doing this is it meets our duties in terms of the rights of the child, like I just said. The project is about providing age and stage information that is useful for you in how you speak about the National Audit Programme with children and young people. So it's going a step further than providing parent and carer reports, and it's thinking about actually how can we engage children and young people in the audit in a different way. And you'll see in a minute just how much children and young people have been keen and gone over and above already to be part of that. We also want to make sure that they are able to understand the link between the questions you ask and their individual experience as a child or young person with health, and then how that scales up to something that could support others. So it's about them, raising their awareness and understanding about audits and what's that about, but also thinking through the difference that they can make and changing some of the experiences that they might have. These pictures were from Stoke on Wednesday night, is that right, Anita? Where Anita's been going off around the country to see children and young people's groups. So this is them doing a word association game on National Paediatric Diabetes Audit. We've got long lists now of what those 4 words mean, so that we can then start to work out through thematic analysis with another group of children and young people, actually what are the key messages that we then need to build on or slightly change. So it's we just thought we'd put those up straight away. And you'll see, hopefully, if you're still using Menti, we've switched to the next question. So what we're hoping to do then is to pull together some principles and some guidance from children and young people, but also best practice about ways to communicate. We're hoping that this provides you with some templates, but also some images, and we're working with an illustrator. We've got children and young people promising to send things to Anita. They didn't want to give back their posters on Wednesday. They wanted to finish them and put more effort into them. So, we've got more coming from children and young people as well. But also giving you materials that you can use as well straight away. So whether that's videos or whether that's leaflets or things that might be useful in clinic, which is why the question on Menti is actually what would be useful to you. So if you can drop a few things in that you think would help you in a 5-minute conversation, or would help you in something that you would email out, or help you with something that would be in clinic, they're the things that our children and young people want to know. And then also, obviously we'll share kind of what's been going on. The Menti will keep running, so don't worry that the code will go off the screen in a second. But I think we just want to let you know where we're up to. So we started this project a couple of months ago. It's actually quite an exciting one. So I'm involved in other audits. So we also do asthma and epilepsy engagement work. This is a very different way that we've gone about it, which is quite interesting. It's potentially going to also lead the other audits in the way that we think about engagement and bringing in children and young people there as well. What we've had, and Anita's been doing the work, there's been conversations with every leading charity, with all the diabetes forums and networks, researchers, with health-based youth workers, just to understand kind of like what it's like from that point of view. So what if we talk about this project, you know, what are we hearing? And on the whole, we're hearing that people are excited that children and young people have got this opportunity, that actually this could lead to some really useful materials, but also a little bit of concern that are children and young people even interested? Would they want to know what the audit results say? Would they want to know this part of what's going on? We did a process, or Anita did a process, where we put out information to see if any children and young people would be interested. 48 children and young people self-referred through the brilliant work of units, youth workers, clinical teams promoting it, which is the most we've had for any project ever. So I would just say that diabetes children and young people absolutely want to get involved in a communications project about the audit. And from that, we've already had 2 sessions, where one in December, where children and young people did not know each other and came together. And there was young as 8 up to, I think, probably like 20, 21 took part. And they took part in a 3-hour online session in December. We then had another session on Wednesday in person in Stoke, which one of the young people from the online session was at, and was already advocating and ambassadoring for everyone else to get properly involved, because this is really important. So I think for us, it's always a sign if they turn up, and they turned up. And then we've already got, I think, 20 bookings for our February half-term in-person day. So there is something about this has captured something in a way, like I said, I've done asthma audits and epilepsy audits, that feels slightly different to what's been going on. But I am quite old, so I'm going to pass over to Krishna, who is just going to talk about why this is important to him, but also children and young people.
Good afternoon, everyone. Just got to say thank you very much for being concentrated and engaged so far and today, because I know you're all busy people and you've got lots to do. I did have a helmet on, and Mum did take a photo of me on the Boris bike, so don't worry about that. I'm a 19-year-old. I study here in London. I'm at first year at university, and I've been diagnosed for 6 years now with type 1 diabetes. And with the meeting with Emma a couple of days ago, I actually found out about the audit itself. So from what I've heard about what's happened in the meetings and through my own understanding and knowledge, I would just say there's 3 things I took away. So one is independence. So with using technology nowadays through TikTok, Instagram, and social media, everyone's about independency and let's do it ourselves. Having this audit did allow us and allowed me to feel less by myself and in my own little world on my phone and on my pump, to being involved and engaged through it all and being, I need to look after this, I need to make sure that I'm getting these tests done. The second one is inclusivity. So it can be a very scarce and lonely world, going to clinic by yourself when you become an adult, or going with a guardian or a parent. By having this audit, you feel less alone, and you can then therefore feel more empowered, more engaged, and more enjoyable in your lifestyle, I'd say, instead of just your care work and your healthcare. And the third one would be empowerment. By having this audit that people around the globe, people around the country, have taken part in, it has allowed me and other people to see the massive picture of what we can do as a whole, how we can help you as medical professionals, and just how we can help our family and friends. Because at the end of the day, it is a community, and it's built on those 3 pillars. And without one of those pillars, it kind of tends to fall apart. And having this audit, having this information, it kind of provides that sense of ease and clarity that you kind of need in a busy world full of COVID, full of rushing around, full of commuting. So yeah, that'd be kind of all that I really have to say. And thank you for taking the time to listen to me. So yeah, thank you.
I would just say, so Krishna's been involved for a couple of years, and it's only because now there's an engagement project that we've been able to talk about diabetes. And it was really interesting when we were outside, we were just talking about tech. So I don't know, do you want to, so you were saying about the fact that you've got kind of like, you were going 1, 2, 3, because I was asking why there's 2 phones, and what does a second phone do? And the second phone is just like amazing at pulling it all together. But we were kind of starting to have that conversation about actually how important it is to have role models, and he was very kindly saying that he's an ambassador for, what were you saying you were an ambassador for?
Oh, ambassador for the pump and then the Dexcom G6 that I have together, just because helped my mum have a good night's sleep, helped Dad not worry about work. So from that presentation that was just before, the work that he did there, that really hit home. I'd say that video was really emphatic and really emotive. So yeah, I'd just say close the loop, and having a pump was great. That's it.
Thank you, Krishna. So like we said, Anita's been doing these sessions already, so talking to children and young people and finding out what they want to do. So the online session that we had before Christmas, we had a juniors and seniors room, and they were both asked questions about what is NPDA, like the word association game, and then we went through the audit findings, and then we started to share. And that's where, like when I was talking it through with Krishna, the thing that really came out was about the fact they had no idea that 34,000 children and young people are living with diabetes. They had no idea then how the breakdown is with the stats with 3% with type 2 and then other people with type 1. And instantly, in these like online groups that we were running with children and people that we haven't met before, they were like, there's a community, there's more people. This is amazing. We thought that actually it was just people in our area. We thought when we went to clinic, it was just the ones that we see in clinic. We didn't realise it was something much bigger. And then they suddenly felt really supported by the fact that there's a whole load of people like you and the audit team at the college that are so interested in making this different for children and young people, that they're doing the work. And that was the bit that kept coming out in terms of this is important. We don't necessarily buy into the words National Paediatric Diabetes Audit, because that's clearly something that resonates with adults. But we understand completely now the principle, we know what a clinical audit is, and actually we want every child and young person to know about this and know that there's someone else out there that cares, that is not the people that you're seeing every day because you know they care. So I think there was something really, really strong in that kind of came out. You can see some of their questions that they were asking us as well. And what's really lovely when you're a youth worker, you just get to go, I'm just a youth worker, so I actually don't know. So let's have a look, let's try and find out. Why don't you ask your clinical team? And most of them we've, kind of like directed them to. They were really surprised when they understood some of the data that not everybody is getting their health checks. And that for them was like a really important thing that they instantly wanted. But also they started to understand why some of the questions come that they didn't always understand. So why people want to see their feet, and why they weren't warned that they wanted to see their feet, and why they would have worn better socks, or why they would have done something differently with their feet, or all of those things. And then they realised, oh, okay, so potentially I'm one of those people that didn't have my health check because I wasn't bringing my feet that day. So they actually started to understand why some of the questions that you ask matter, and then why it would matter to be part of something that matters to other children and young people. And I think that is the bit that is also quite interesting. And you can see some of the other questions there, instantly being interested in other children and young people and wanting to know, is there a reason why type 2 children and young people are not engaging in health checks more than type 1? And getting straight into it. And like I said, children and young people, first time meeting us, first time hearing about the audit, and from really different diverse backgrounds, different needs, different communication preferences and styles. And then they started to think about, what did they want us to do if we were creating information with them? And you can see kind of like their top tips. So the 2 juniors and seniors groups did theirs in December. The Stoke group in person on Wednesday pulled those 2 together, added to their own, and then turned it into some kind of like guiding principles for us to think about as we go through the project, but also then as we kind of like share what matters. So please don't patronise. We know that. And I'm sure nobody goes into writing a health information leaflet to be patronising, but there's a fine line between cartoon images, stock photo images, information for everybody compared to information for a 17-year-old or for somebody who is 5. And, us just really understanding sometimes information's not landing because we haven't got a couple of different versions. But also role models. So, which is why, Krishna, I said, when you were saying outside, I'm a real ambassador now for, how this tech has helped me. And I was saying, and you're at uni. Some of those children and young people in December thought they couldn't go to uni because they have diabetes, and they're like 9 and 10, making decisions already not to, put themselves forward at school because they can't go because they've got diabetes. So I was just saying to Krishna, when you come to that one and you say you've been at uni, that will change already some aspirations and perceptions. We also, got some comments about why they think this project's important or what they would like you to know. So it was really clear that they were really pleased to have the chance to help other people. A lot of the conversations that they end up having is about diabetes doing something to them, and then health doing something to them to kind of combat what diabetes might be doing. And they really like the fact that actually this was just them being like 12, doing something for some other children and young people that they've not met before, but now they know there's 34,000 of them. So, they didn't feel alone. They thought it was important. They'd quite like people to know what they're entitled to, so they understand those 6 checks. That was just going round and round and round. About having different opportunities to feel heard, that they want to kind of like exceed whatever we're saying is the minimum standards and to try and do even better, which was fantastic. But also, to help people feel supported, and then to think about actually how they can feel like VIP advisors, which is what we tend to call our children and young people. Because again, we know from all of our groups that long-term conditions often take from them. And this is a way for them to, kind of be empowered as a community of children and young people, rather than, the great work that you do to make sure that happens on a very individual, local basis. This was them really seeing themselves as part of a bigger number, which was fantastic. So just to let you know what you've said on what resources would be useful, we've got information in different languages, videos, leaflets, posters, infographics, posters, age-appropriate pictures, which is one of the things that has come up from children and young people, online tools, flashcards, packs for families, again, child-friendly literature, information in different languages. You've come up with so many ideas, this is amazing. A poster with a short leaflet, simple pictorial leaflets, explaining what is this, why is this done, how will it help me, social media links, links to things that are happening for families at a local level. So your last question is now up, which is, how will you use the learning? And it was great to see in the room, lots of the cameras came straight up to take photos of what children and young people had said, or what their questions are or what matters to them. And I'm sure you were doing that online. There might have been some busy writing down. But how does this make a difference for you? So we know it's the right thing to do because it's children's rights. We know how we're thinking through what we're going to do to be successful. But I guess this question is about you and everyone online. How will you use the learning from children and young people to support your work and that of the NPDA? So that is us. We can take a few questions, I think. Krishna, are you happy for that?
Yeah, that should be fine.
Wicked. Thank you.
Thank you very, very much. I'm sure there's going to be a few questions. I think it's reassuring to know that eventually 33,000 children and young people are going to know that we're not a weird bunch that just go, can we get a little bit of urine, please? Just a few drops. Questions?
Hi, Krishna. Thank you for great presentations. I just wanted to talk a little bit about, or for you to tell us a little bit about the process you go through with safeguarding consent when you're working with under 18s and what you have to go through to make sure you're doing all the right things. Yeah. And Krishna is also wanting to ask you about, it sounds like you're incentivized to work on this project because you're helping lots of other people, but do you think there's other incentives to bring other children, young people on board?
Do you want to, yeah. Okay, so there's a whole process, you won't be surprised to hear, about safer working practices with children and young people. And we've got some training and some guidance that we do on it. So basically, the Department for Education and Government has laid out a set of principles that they would expect anybody doing work with children and young people that is extracurricular, so sits outside of school, as to what you need to follow. So it's about creating kind of like your field file, it's called. That means that we always have a risk assessment, individual wellbeing plans. We make sure that we've thought through that we've got mental health first aiders in any of our sessions. We're looking at ratios, so what's a safe ratio to do our work. So the online session, for example, had 11 children and young people in December, we had to split that into 2 groups, so it was safe with the youngers and olders, which meant then that we had to have 2 staff in each. So we had 4 staff, which, you know, some people will feel that's too much. It's completely safe. We also had backup staff if we need it, because you don't know what's going to come up, and you have to really make sure that you're able to cater to their needs and their experiences, but also give them time. So ratios is one bit. We also go through a consent process, which is providing kind of like parents and carers with the information, so they know what our background is as professionally qualified youth workers, how we think through all these things and what we do to keep them safe. But then also we consent with the children and young people, because they need to be able to know what's going on as well. So, you know, consent's different across the country as to the ages that you need to consent with children and young people, and it's different according to what platforms you're using. So again, that gets taken into account in our digital assessment of any work that we're doing. I'm trying to think what else there is. Then we have a project plan that goes through what we're trying to do, how we're not going to cause extra harm by what we're trying to do. And that, again, thinking about the December session, was something that we talked about as a team. You know, when you open up, you know, the first chance really to be sometimes for some of those children and young people in a group talking about this, and you want to say, what is your hope for other children and young people? You might get very personal reasons, particularly for some of the older ones, that you wouldn't want the younger ones necessarily knowing that that's where, you know, some children and young people have gone to. So then you have to think through how you're going to manage that in the moment. So, you know, there's lots of kind of like wraparound stuff, and I think the thing that's really worked for us is we come from a professionally qualified youth work background. You know, this is what we're trained in, and also then this is how we're able to provide training to others to know how to do this. But it's not a quick process, and I know that in our training, there's probably about 17 things that happen before we get to the point where, can we invite a child or young person to this? So it's you know, it's really good that you've brought that question up, because I think for us it's about not being reductionist in what we're doing. It is skilled and takes time, but actually safeguarding, well-being and a communication preference assessment are always the top 3 things that we look at first, which is why we use symbols, why we have interpreters, why, you know, we use different ways to work with children and young people. Incentives, I will pass on to Krishna, but just so you know, the children and young people that were invited to the project have been offered no incentives. The incentive is only to make a difference. They're not offered vouchers, they're not offered pizza, they're not offered food of any description, they're not offered goodies, they're not offered anything. We add some of that on after, but what we want them to come and do is to be altruistic in their volunteering and to make that make a difference. So recruiting across the country, not offering anything, is quite unusual, but we're kind of holding on to the fact that actually that's what's important to us. So yeah, they don't actually get offered anything, which is why, you know, we were really impressed that so many put themselves forward. How did we incentivise you today, Krishna? What did we give you?
They sent me a message and removed my mum from the WhatsApp group chat, because being an 18 plus now, I have the ability to consent, do all the welfare forms by myself. So that was the main thing. But then 2 things I'd say the incentives for me to do any volunteering. One was to be informative. So my dad's a doctor and my mum's a biology teacher. So we have a lot of biology textbooks out in the house. So during diagnosis, I think I ran up into dad's office and plucked 1 or 2 and just started reading them, just to kind of calm my own mind. And I know that a lot of people are quite daunted, quite worried about looking into this. What does it do? How does it affect them? So that was the main thing, to try and give back, give information, coming from someone who will probably play Fortnite with them later, or they'll see on the football pitch. And then the next one would be emotive, because I know that this isn't just medicinal. This is a hard-hitting condition that everyone's kind of affected by. Like, mum has to look out for what she's cooking. Dad needs to make sure if he's taking me to rugby, is there orange juice? Is there a banana in the car? My sister's like, she's in London as well. If he's drinking, now that I'm 18 plus, is he drinking the right things? Is he safe? Things like that. And a lot of people don't have that kind of care and that background behind them. And that was the main thing for me, that I've been blessed during my diagnosis in KGH and NGH in the Midlands. And I just wanted to give back to as many people as I can in the best way and the safest and happiest way, just for them as well. So that would be it. So thank you for the question.
We're into the coffee break now, but is there any other question that anyone would like to ask? Because we can grab a coffee and then come back. But if not, thank you both so much. I'm really looking forward to what the outputs of this exercise will be. It'll be really insightful for all of us. Thank you.
Thank you for having us.
So we have a quick coffee break now. If you could come back promptly for 1:15, which doesn't leave much time, so it's grab a coffee and come back, please.